sounds mostly like a crisis intervention type thing with the person in need of early services so they don't get to that point. Doesn't sound like you're saying that those are there.
Again, in my region, we have community-based mental health services. They have a wait list. Everything has a wait list. Mm-hmm. And like I said, it's something that I struggle with considerably because it's it's a very painstaking process to take my wait list and figure out who's the next person you're going to see. Because you give that slot to one person and there's 150 that are trying to take it. And so, like I said, again, it's the same issue. We have a process whereby most of the energy is put on, as we've said, Band-Aid solutions, and if you really want to get access to services, we've identified it's often people who end up in the emergency departments and are very much in crisis. And it's just really, it's a numbers game. We just don't have the resources to do that prevention and those primary interventions.
And it's really hard to sort of look at your list when you have referrals coming through and trying to decide who takes priority over someone else. It's really hard to sort of make that decision because behind every person there's a family and their job, and more people than not who by the time they get to see me have already been off work for a year. And the longer you're off work, the less chance that you have for having a successful return to work. So even if someone started off when they were initially referred, not in the dire circumstances that they're currently in, by the time they get to us, they often are, and the situation is harder to deal with. And I think family physicians are overwhelmed with the complexity of many of these patients, and their general patient load are becoming more complex. And I think about when my practice partner and I first opened our clinic, we went home 5 o'clock one evening, we came back 8 o'clock the next morning, and there were 40 referrals on our fax machine from 5 o'clock that night until 8 o'clock the next morning. I can't see 40 people a day for an hour apiece. There's just not enough hours in the day for me to do that.
You say your practice is full right now, it's running at full capacity. You're also saying that there's enough doctors here in St. John's for the adult patients in the city. So are you saying that the problem really is outside the overpass, it's in rural? If there was enough doctors in rural Newfoundland that the patients could stay in their communities, maybe you wouldn't have the heavy workload that you have currently right now?
That would definitely make a big difference because, as Dr. Luscombe's already said, rural Newfoundland is working at 50% capacity. So all of those patients who can't be seen by Dr. Luscombe and his colleagues or in communities where there are no psychiatrists, they end up trickling down to those of us who are in the city. I think that of my patient list, like of the people who I currently see, there's a large percentage of them that if there were accessible services and psychiatrists more local to their communities, that they could be transferred to those, which would mean that the people who currently sit on a wait list who are from the Avalon Peninsula and the city who are waiting to see me wouldn't wait so long.
I think it's not only the shortage of psychiatrists outside of the overpass, if you like, but the family doctor physician problem, because psychiatric patients take longer. They do. I think, we often book an hour and a half, maybe 2 hours for a first assessment. Family doctors can't do that, and that's fair. But very often, even the in-between visits are much longer than what family physicians can do. Yeah. The other thing is that they're very often transient. That's our sense of what happens in many rural communities. The family doctors are transient. And I don't think our patients really want to go and tell their psychiatric story and their mental health history and their family history to a different doctor once a year, never mind in some communities, maybe once every 3 months. And it's easier to follow up with the psychiatrist. The other issue that happens when waiting lists are so long, when patients do get in, they don't want to give that up. I finally got the lucky ticket, the pass that gets me back to a psychiatrist. If the waiting lists were shorter, then I think more people would actually be willing to go back to their family doctor following a consultation, knowing that if they needed to see a psychiatrist again, they might get seen in 4 to 6 weeks instead of 4 to 6 months or 2 years. So they would be more willing to go back and use other services. The other thing is, because often there's no lack of allied health professional supports, we do a lot of that, and we wind up doing some of the things that other allied health professionals could be doing with our patients in order to support them, and that takes time. and they're often the talk therapies, and they're the things that take a long, long time. And I don't want to be reduced to just prescribing medication. I wouldn't want that. But I think that because of the low numbers of other people to provide those services, we wind up doing a lot of that as well.
What, is it just money that would attract more doctors, especially to rural, more psychiatrists to rural? What, how do you fix
If we're about
that
money-
recruitment problem?
If we're about money, I wouldn't be here. I wouldn't be practicing where I am. You know, very much, I think that, you know, what we're looking for and what I'm looking for is to feel that I'm doing a good job, to feel that I'm contributing to the community, to feel that I am valued, and to not feel overworked. I have a family as well. You know, I want to have some balance. It's interesting because, you know, I'm from rural Newfoundland. I had a vision of going back and practicing and participating in all the recreational activities that rural Newfoundland has to offer, and I've quickly realized I have no spare time to enjoy that. It's just, well, I lived in St. John's and took a weekend to go out there. So, you know, it's very much about, you know, what we're looking for is system-based solutions that make sure that the right people get the right service at the right time by the right provider. And if we can start having those efficiencies and helping to enlarge the system, and not just psychiatrists, not just, you know, we're talking very much about all of the care providers for mental health. We need to raise all of their capacities, and that's going to serve the population and make all of us feel we're doing a good job at the end of the day.
But with only 12 graduates a year, wouldn't this province really have to go above and beyond what other places are offering rather than even just matching other places to be able to get more people there? And if so, how much further does the province need to go to get to that place?
The 12 graduates is specifically around child and adolescent, and we've been really lucky because we've been able to train people and they've stayed for the most part, at least for a little while. If we had been able to retain every psychiatrist that Memorial had trained, it averages out to about 4 a year. You can imagine where we would be. It would be a very different place. But the reality is we recruit and retain many fewer than that. I think that money is one of the issues when you can go to Nova Scotia and start out at a third hire, do no call, have the allied health supports and the lifestyle issues. So money is not all of it. Lifestyle is huge. I can't imagine being Dr. Luscombe and being on call every second or fourth night. I've done it. If I had to go back to it, would I still stay? Or am I old enough and gray enough now that maybe I could argue with my colleagues that I shouldn't have to do it? Because when we do call, for example, just like everybody else, you're up all night, you worked all day, you work all day tomorrow. And when you have young children, that's really problematic because when you get home, you just don't have the energy for that. And so I think lifestyle has become increasingly important and maybe more important than remuneration at the end of the day.
I mean, I think remuneration is important. I mean, I guess I came out 3 years ago. It is a factor, and I think that people have to realize it is a factor that plays into it. I came out of residency, I owed $150,000. That was what my education cost me. And I didn't take fancy trips to down south every year, and I didn't go to Europe. And, you know, I lived with a bunch of people, and I kept my costs down as much as I could, and I came out with $150,000 owing. Anybody coming out of any program, any discipline, regardless if it's medicine or nursing or journalism or teaching, they want to pay off their debt. So if you can go to New Brunswick, as a very close friend of mine who graduated the same year as I did, and you can go to New Brunswick and you can make $100,000 more than I can make, then where are you going to go when your panic is about getting your debt paid off? I mean, and then of course, as Dr. St. John says, I mean, obviously, if there was 10 more hours in the day and I could work those and, you know, make that same amount of money, would I do it? Well, no, because I want to have a life and I want, you know, to be able to enjoy my family and enjoy what the province has to offer. So there is a balance, but yes, each thing plays an important point.